It's all up to you now. Yeah.
Shall I start the video?
Yes, we can already see your screen. We can see
Okay,
the
great, great.
presentation.
Do we have enough candidates to start the session?
Yes, we have. Even if we don't, we start at a given times. We do not wait for everyone to join.
Okay,
So
that's
we
great.
usually people have joining maybe 5 minutes late. Sometimes some candidates join late because they are working till late. So we just start
Mhm.
at the specified time.
Okay, good evening, everyone. My name is Dr. Mitesh Kumar, and today I'll be talking about approach to shoulder X-ray. Many thanks to Dr. Sandeep Awal and Radiology Vibes team for giving me the opportunity to share my knowledge on this topic. In this talk, we will be covering normal view of shoulder joint, checklist for reporting shoulder X-ray, common pathologies affecting the shoulder joint, followed by a practice session. The view of shoulder joints is AP view, axial view, lateral scapular view, and apical oblique view. Now, this is an example of a AP view of the shoulder showing starting from here, neck, aortic knuckle, hilum, lungs, pleural space, ribs, clavicle, scapula, the acromion process, coracoid process, glenoid rim, lateral border of the scapula, medial border, spine of the scapula, head of the humerus, greater tuberosity, and the shaft. Now, this is an example of an axial view of the shoulder joint. This is taken with the patient lying prone, and the X-ray beam is projected towards the shoulder joint, making 25 degrees from the table. And this is how the X-ray will appear. Here we can see the coracoid process, acromial process, glenoid rim, and the humeral head. Now, this has been described as a golf ball on T appearance, in which the humeral head is supposed to be a golf ball, which is sitting on the glenoid rim. So, in this X-ray, we can diagnose glenohumeral joint dislocation, that is the anterior and posterior dislocation, also fracture of the coracoid process and the acromial process. Now, this is a very good page on Instagram to look for anatomy of all parts of the body. Next is the lateral scapular view. In this, what we can see is that the humeral head will sit on the Y, which is found by the acromion process, coracoid process, and the blade of the scapula. So the humeral head will sit exactly at the same point. Now, in a perfectly taken lateral scapular view, one should be able to see the Y properly. That is, the overlapping scapular blade should be seen as one line. In this, for example, if you see here, it should be seen as one line. If some part of this scapular blade is seen, it means it's a poorly positioned X-ray. Next is the apical oblique view. In this, we have to make a triangle in which the base of the triangle is found by the glenoid rim and the apex is here. So whenever we draw a line from the apex towards the base of the triangle, the head of the humerus, center point of the head, should intersect this line. So if the head goes superiorly, it means posterior dislocation, and if the head goes anteriorly, it means anterior dislocation. Now this is again example of posterior dislocation. In apical oblique view, we should always look at the glenohumeral joint articulation, and in addition to that, we should look at fracture of the humeral head and glenoid rim fracture. So this is an example of anteromedial compression fracture resulting in reverse Hill-Sachs lesion. So here we can expect reverse Bunkard lesion here, but unfortunately in this we do not have this. To be rapid reporting requires a lot of practice, and one of the best book available for this is Accident and Emergency Radiology, a Survival Guide. I recommend everyone should read this book minimum 10 times before going to the exam. This is the link to buy the book. Now, starting from the checklist, I want all the candidates to grab a pen and paper so that they can write this checklist. We will be using this checklist in our practice session. Please grab a pen and a paper. Now starting from the first point, the neck. Here we can see some part of the neck. So we can expect some kind of lumpy bumpy appearance in this, which could be either a thyroid mass or a lymph nodal mass or mass of any etiology. So we should always keep an eye on this lower part of the neck. This should be followed by looking at the apex of the lung. Here we can expect some kind of opacity, smooth or ill-defined opacity in the apex of the lung, which will represent Pancoast tumor. Next, we have lungs and hilum. In the hilum, it should have a very less density and it should not have a lumpy bumpy appearance. Any lumpy bumpy appearance means lymph node enlargement or vascular pathology. In FRCR 2B rapid reporting, all we need to say is bulky hilum, not necessary to specify whether it is due to enlarged lymph node or blood vessels. In the lung, what we can see is some soft tissue mass, or we can see a cavitating lesion. Now coming to the pleural space, look at the pleural space for any pneumothorax. Not necessarily it will get confined to here, it might go up here. So in shoulder joint, we should always look at the pneumothorax. Then again, always look for pleural effusion. Now in the ribs, we should always look at the anterior end, angle and the posterior end. All the parts of the rib we should look at. Now coming to the clavicle, always look at the medial end of the clavicle, superior border, lateral end and the inferior border. We can have a fracture as something like this or a step in the cortex which represents fracture. Next is AC and CC joint, acromioclavicular and coracoclavicular joint. Here, the distance of AC joint should be less than 5 mm and the acromial part and the clavicular part should align with each other. Whenever we see AC joint subluxation, always look at the CC joint also. Normally it should be less than 13 mm. More than 13 mm mean CC joint, CC ligament injury. Now coming to the next part is the scapula. Always look at the whole part of the scapula. Means the body, acromion process, coracoid process, glenoid rim. Always look at the glenoid rim properly to look for any subtle fracture and spine of the scapula. This is how the fractures will appear. Next is glenohumeral joint dislocation. This could be either an anterior dislocation in which the humeral head comes inferiorly and with respect to the glenoid rim, or we can have a posterior dislocation in which the humeral head will go superiorly. Sometimes we can have a joint effusion which will appear like a fat blood interface, just like we see in knee joint. In humerus, we can expect fractures anywhere in the humeral head, in the greater tuberosity. We can have a Hill-Sachs lesion or a reverse Hill-Sachs lesion. In the last, supraspinatus calcification. I hope we are clear in this part. Now we'll discuss about few important pathologies. The first is anterior dislocation. In this, the humeral head lies anterior inferior with respect to the glenoid rim. This can be associated with Hill-Sachs, Bankart lesion or a fracture of the greater tuberosity. This is an example of Hill-Sachs lesion in which there is compression fracture of the posterior lateral part of the humeral head appearing like a step-like defect. Normally, we should not have anything like this. Next is the Bankart lesion. Here we can see there is a small fracture of the anterior inferior part of the glenoid rim, this small fracture. This is called bony Bankart because we have a fibrous Bankart which is seen on MRI. Same patient CT done in which we can see a small fragment in the inferior, anterior and medial aspect of the glenoid rim. For anterior dislocation, one view is enough. The second view is taken mainly to confirm the diagnosis and to look for associated fractures like fracture of the greater tuberosity, Hill-Sachs lesion and bony Bankart. Unfortunately, I do not have an X-ray showing anterior dislocation in a lateral scapular view, but what we expect is that the humeral head will lie here. Anterior dislocation means the head will shift towards the ribs, whereas in posterior dislocation the humeral head will go away from the ribs. This is how we interpret lateral scapular view. Now, regarding posterior dislocation, the causes are trauma, electrocution and epilepsy. Here we have light bulb, reverse Bankart and reverse Hill-Sachs lesion. Now let me explain you the pathology behind this light bulb sign. This is an example of a normal AP view. Here we can see that whenever an AP view is taken, the arm is slightly externally rotated. So this gives the appearance of a walking stick. Here we can see some asymmetrical appearance of the humeral head. Now compare this with this. Here we can see symmetrical appearance of the humeral head, just like a light bulb. So this is how we can differentiate between a walking stick and a light bulb appearance of the humeral head. Light bulb is seen as posterior dislocation. Apical oblique view in which we can see that the humeral head has gone superiorly. This indicates posterior dislocation. Here also we can see reverse Hill-Sachs lesion. Lateral scapular view. Here we can expect the humeral head to go away from the ribs. It will be away from the junction of this Y. Now regarding the AC joint, this is a normal AC joint. The distance should be less than 5 mm and the acromion and the clavicle should align with each other. That is, if we draw a line from the inferior cortex of the acromion, it should meet the inferior cortex of the clavicle. Whenever there is AC joint subluxation, we should always look at the coracoclavicular joint. For example, this is a clear-cut case of AC joint subluxation. In addition to this, we can also see widened CC joint. CC joints, it means coracoclavicular joint ligament injury. Here again, example of normal AC joint and coracoclavicular joint. Here we can see subluxation of the AC joint. Now I would request the candidates to take out the checklist and we'll start the practice session. Now, Dr. Sandeep, how shall we proceed?
It's up to you, Dr. Mitesh. If you want people to give out the answers in the meeting chat, I think everyone gets to answer that way rather than picking up specific candidates.
Okay.
That is my suggestion. So they can just type in their answers in the chat box, and then after few 4 to 5 at least responses, then we move forward.
Okay,
so
fine.
We have the first response coming.
Dr. Sandeep, please keep a look at the chat box.
Yes. So I'll also inform you, if you allow me.
Please
inform you about what people are answering. So Dr. Rafiq has said subcoracoid anterior dislocation. Dr. Rafiq, you did say subcoracoid anterior dislocation, but which side? You have to mention the side as well, right? Then there's left anterior shoulder dislocation, left anterior dislocation with Bankart. So anterior dislocation of the left side seems to be the common answer. Dr.
Yeah, that's true. That's true. Along with that, we can see fracture of the greater tuberosity. Hill-Sachs will appear the compression. This we can see fragments here. Okay, fine. We'll go to the next case now.
So what should be the final and correct answer to write in RAPIDS in this case? Oh, perfect. That is
So,
perfect. So this is answering
yeah, here we
candidates.
have left anterior shoulder joint dislocation with fracture of the greater tuberosity.
What there's sometimes the question arises, if multiple findings are there, suppose in this particular case, and I write left anterior shoulder dislocation, I hope I'll get the full marks, right? Is that so?
No, it is not like that.
Okay.
If there are two findings, the examiner will expect the candidate to write both the findings. Otherwise, you will get 1 mark.
Okay. But just to inform the candidates, usually, most of the times, there will only be one finding. And
That's
even if
true.
there are two findings, one finding will be very, very prominent.
True.
And the other one will usually be very subtle. So they usually do not give cases with multiple findings in rapids.
100% true. One thing is there, for example, if someone has given an intra-articular fracture with joint effusion, then both the finding needs to be mentioned.
Absolutely. Yeah.
Yeah. For example, in shoulder joint, in elbow joint and knee joint, both the fracture and effusion has to be mentioned.
Absolutely.
I hope this is clear to all the candidates.
Absolutely, Dr. Mitesh. We agree with
Now, we'll go to the next case. Case number 2.
So, participants, please type in your answers, whatever you see in this particular rapid. So, Dr. Mitesh, the common answer that we are getting in the chat is right humerus leg fracture or right proximal humerus fracture.
Yeah, humeral head fracture. Yeah. The idea behind showing this X-ray is that in chest X-ray, always look at the shoulder joint. This should be your aim, not only in FRCR 2B exam, but also in your clinical practice. Similarly, in shoulder joint, always look at the whatever chest part you can see. I think perfect. Everyone has mentioned fracture neck of the humerus. Fine. We'll go to the next case. Case number 3.
So, Dr. Mitesh, we have a few answers coming in. Just before I tell that, I see few candidates who are just writing. The common answer is right posterior dislocation, but few candidates are answering just posterior dislocation. What do you think, Dr. Mitesh? Should these people?
Yeah, we'll tackle this.
These people be writing the side as well?
Perfect. Yeah, they have to. But since it is only a right X-ray, so I think better to write shoulder, specify the site also.
But then my question to you would be, people are writing posterior dislocation. That could be a posterior dislocation of the clavicle or the first rib. Anything can get dislocated, right? Most of these people have not even specified posterior dislocation of what? Of the right shoulder?
Yeah, right, I think, yeah, you're absolutely right.
You need to specify, right, what is getting dislocated.
Right shoulder joint dislocation.
Yeah, absolutely.
Posterior.
So everyone now, please note that.
Yeah, there's a catch in this. Now, if you look here, you can see some break in the cortex and area of lucency here. And again, there's a break in the cortex here. And this, in the next view, you can clearly appreciate there's a fracture in the surgical neck of the humerus. So even I thought this could be a posterior dislocation. But again, this is a neck of fracture. I hope everyone is getting this X-ray. Hello?
Yeah, I am here. I'm just waiting for the people to answer in the chat box, and most of them say yes.
Yeah, true. Is there dislocation in this case? May or may not, I don't know. But the main area of concern is the fracture, which we can see clearly here, the break in the cortex, wide zone of fracture here, and again break here in the medial cortex. Anything you want to add, Dr. Sandeep? In this
I personally don't feel that there is a shoulder dislocation in this particular radiograph. I can see that the overlap of the humeral head and the glenoid looks fine to me.
True.
So that half moon overlap sign is there. I would not say this is a dislocation.
Yeah, true. Another point is that since this patient has a fracture, what happens is that the patient, instead of when the patient goes to the X-ray department, the radiographer won't be able to externally rotate the shoulder. Hence, the patient will keep it internally rotated. This mimics a light bulb sign. So we need to see in the another view. That is why we need two views in the shoulder joint. Here in this view, we can clearly appreciate the neck of the fracture.
Exactly.
So now we'll move to the next case. Another case.
So participants, please type in your answers. What do you think about this particular rapid? Is it normal or not? If it's not normal, what is the diagnosis? So I hope, Dr. Mitesh, you are able to see the chat.
Yes. Yeah, I'm able to see the chat box. And yeah, few candidates have written it correctly. Right humeral neck fracture. Clearly, we can see the break here and the break in the middle part. So this is a surgical neck fracture. Now we'll go to the next case. So the idea behind showing this X-ray is one has to train their eye to look at the cortical break. There should not be any step-like defect anywhere here in the middle part and the lateral part. In other view, we can clearly appreciate the neck of the humerus fracture. Next case. Candidates, please type your answer. Yeah, I can see few candidates have written correctly. Inferior shoulder joint subluxation. Someone has written joint effusion, but we'll discuss about that part in another X-ray. Now this is a case of inferior dislocation. Now this could be due to post-traumatic etiology or even in some patients of hemiplegia where the deltoid will lose its tone and there is inferior subluxation of the humerus. Yeah, few candidates have written it correctly. Inferior shoulder joints subluxation. Next case. Yeah, very straightforward case. Left AC joint subluxation. We can clearly see that there is a step-like defect seen between the acromion and the clavicular part, and if we draw a line from the inferior cortex of the acromion process, it does not meet the inferior cortex of the clavicle. Well, someone has written, why can't we say dislocation, where in AC joint subluxation or dislocation, usually it doesn't matter much. People just write subluxation or dislocation. Here we can see that some degree of articulation is still maintained. So this could be subluxation. Now we'll go to the next case. Oh. Yeah, few candidates have mentioned correctly. Supraspinatus calcification with fracture of the greater tuberosity. So this is the supraspinatus calcification, and here we can see area of break here, going down, 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 and this step break here. So supraspinatus calcification with fracture of the greater tuberosity. So here we can see that there are two findings. It's better to write both the findings to get full marks. Next case. Yes, few candidates have written correctly. Fracture of the greater tuberosity. Here clearly we can see a break here, the fracture line here, and the break here. Fracture greater tuberosity. Next case. Please use the checklist. Yeah, fine. Many candidates have written fracture of the scapula of the body. Here we can clearly see a break here and the fracture line going inferiorly, medially, laterally, and here we can see another fracture fragment. Now what happens that not necessary that in all fractures you will be able to see a lucent line. Sometimes if the opposing fragments are compressed with each other, we can have a sclerotic line. So I'll show you one X-ray in which there will be a sclerotic line. Fracture of the left scapula. Next X-ray. No, there is no lytic lesion. Someone is asking, where is the lytic lesion? No, there is no lytic lesion. Yeah, majority candidates have written it correctly. Right supraspinatus calcification. But in addition to that, there is a small fragment here. Oh, I forgot to mention here, but there is a fracture of the glenoid rim. This is a small fragment here. Now we'll go to the next case. Yeah, few candidates have written correctly, Bunkat and Hill-Sachs lesion. So we'll see how it is. Clearly we can see a bony Bunkat here and a step-like defect seen in the superior posterolateral aspect of the humeral head. So anterior dislocation with Bunkat and Hill-Sachs lesion. Perfect. Next case. Now someone has written posterior dislocation. No, it's not posterior dislocation. Clearly we can see the humeral head is sitting more or less in and around the Y. Please show the previous radiograph. Okay, I'll show you 1 minute. So this is normal lateral scapular view. We can see the cortex is well maintained. There is no fracture here. This is for the someone who is using iPad 2. They requested please show the previous radiograph. So this is the bony Bunkat and the Hill-Sachs defect. Now we'll go to the next case. Please use your checklist. Perfect, perfect. Right pneumothorax. So in all shoulder joint, always look at pleural effusion and pneumothorax. Perfectly, everyone has written right pneumothorax. Great, great. The visceral pleural line and avascular area. Next. Vikas, please write correctly. Humeral fracture, where is the fracture? Specify the part of the humerus, please. Yeah, neck. Perfect. We'll see fracture neck of the humerus. Clearly, we can see a step-like defect here. The break in the cortex. Next. No, there is no rib fracture. Someone has mentioned rib fracture. Humeral neck. Clavicle, no. Okay, fine. Yeah, this is clavicle fracture. Nothing much. Clearly, we can see a break in the cortex. Now, this. Sorry for using this kind of illustration. The idea behind using this kind of image is to show you all the spectrum of pathologies affecting the shoulder joint. Just imagine you are seeing this X-ray like in reality. Yeah, it's a normal X-ray, but I have made something here. Please concentrate on this part. I have made something, I have drawn something here. Yes. Chetra has mentioned effusion, yeah, query, yeah. Hemarthrosis, yes. So this is how I wanted to show hemarthrosis, fat blood interface. Unfortunately, I do not have an X-ray, so I just thought of showing you guys something like this. Some pediatric X-ray shows clavicle looking like fractures, but it is normal. How to confirm that? Try to get a second view. Another spotter. Now let's see. Yeah, fracture scapula. We can see a break in the cortex and this head fracture line. Yeah, next X-ray. Please use the checklist. Now let us see what it is. It's a normal X-ray. So the idea behind showing is that if you are not able to see any pathology, it is most likely normal. I remember Dr. Sandeep, when I gave my FRCR 2B exam. Dr. Sandeep, are you there?
Yes, I'm there.
When I gave my FRCR 2B rapid reporting, I hardly used the function of pan, zoom, and adjusting the windows. Exactly. Maybe I might have used in 1 or 2, 3 cases, but usually one should not have to dig out too much to look for pathology. If you are digging too much, it means you are looking for something really very subtle, and it is most likely normal. Am I correct, Dr. Sandeep?
Exactly. So that time you're more likely to overcall findings rather
true,
than
100% true.
Correct. And what people do from my experience of teaching is that most of us are practicing on laptops with very small screens. So true. We train our eyes to look at fractures or radiographs in those particular small screens, maybe 14 inches big. That's as far as we go. Sometimes these candidates are using an 11-inch iPad. But then when you go to the exam, you'll have a larger screen. So I realized this very long before my actual exam when I went to the ARI course. And then I saw their screens, and then I ordered the exact same kind of screen for my personal work as well as the same kind of keyboard. So I'm currently also doing this session on that particular screen. So I trained my eye on the larger screens, and then as Dr. Mitesh said, you hardly will require zooming in those kinds of screens. Most of the radiographs will be very clear and crisp in the actual exam.
True. Another thing what I have noticed from my personal experience, that if suppose whenever we open any image, it opens with a default window settings. And if it's a chest X-ray, and if you see that the lung is unusually bit dark, usually there will be some pneumothorax somewhere. So you are, in that case, you might have to adjust the window. This is just from my personal experience after attending the exam and few courses. Dr. Sandeep, you want to comment on this?
I totally agree, Dr. Mitesh. I totally agree.
Pardon?
I totally agree with you.
Oh, yeah, true. Okay, fine. Now we'll go to the next thing. Yes, it's a normal axial view. Next. Yeah, few candidates have written correctly. Hill-Sachs defect. A step-like defect in the posterolateral aspect of the humeral head. Hill-Sachs, perfect. Now we'll go to the next X-ray. Yes, AC joint subluxation. Now this is clear-cut dislocation. AC joint dislocation, yeah. Next. Yeah, again, same pathology, left AC joint dislocation. Yeah. Next X-ray. I think this has been, okay, fine. Right pneumothorax, perfect. Next. Yeah, many candidates have written correctly. So now see, this sclerotic line, this is because the fracture fragments are opposed to each other, producing a sclerotic line. So not necessary that in all fractures you will get a line of lucency. It could be a sclerotic thing. So this principle is applied to everywhere. Even in skull, if you have a fracture fragment which is impacted, you can have a sclerotic line. Next. Yeah, fracture of the neck of the humerus. Yeah. Sorry for using again this kind of image. The idea behind using this is to show all the spectrums affecting the shoulder joint. Pancreas tumor won't be this big. Yeah, it's a bit tricky, I understand. So this is actually a hilar mass producing a golden S sign. So left upper lobe collapse, hilar mass. Next X-ray. Yeah, only one candidate has written, candidate number 2 and Shabha, they have mentioned fracture of the ulna and the humerus. Perfect. So always look at the corner of the image. Some pathology will be hidden somewhere. So this is an example showing the humerus fracture and the ulna fracture. We'll go back to the X-ray. Humerus fracture and the ulna fracture.
So, Dr. Mitesh, sorry to interrupt you. What about the subcutaneous emphysema? So
yeah, even that is there. Yeah, that is also there.
Thank you so much.
Fine. So we have finished the part 1 session, and now Dr. Sandeep will take the Viva session. Any doubt? We'll be continuing with the part 2, in which again I have collection of few X-rays of the shoulder joint. We'll be conducting that next Sunday.
So thank you so much, Dr. Mitesh. Wonderful presentation. I hope many of us revised a lot of things, and I learned a lot of new things as well. Few things which I did not learn during my rapid preparation as well. So wonderful session, and we all look forward to your future sessions with us.
Okay, fine. Dr. Sandeep, I want to show one case today.
Yeah.
Could you please disconnect me so that I can upload that case?
So you want to upload a certain case, right?
No, I want to show. I'll stop sharing my screen.
Just before you share it, I hope that the case is anonymized and we
it's
going to see the patient name on that particular case. So you can just click escape, ESC escape.
I'll start the stop share.
Yeah, that is also fine. So in the meanwhile, if people have particular questions regarding this particular rapid session from me or Dr. Mitesh, you can type here, or better you can type in the FRCR June group or in the Essentials group. So wherever you are there in the Telegram groups, you can post it there. We will try to give out our answers.
Dr. Sandeep, in last 3 days in fact, I've seen so many abnormal X-rays of shoulder joint. I've added at least 10 X-rays since last 3 days in this in this case.
Perfect, Dr.
This border
Mitesh.
region.
And I'm sure all of our participants agree that your your set is a wonderful collection. We hardly get to see such varied type of shoulder X-rays in our particular institutes. So thank you for showing your collection, Dr. Mitesh. So we can see your screen.
We'll just go 5 minutes more, Dr. Sandeep.
Yeah,
That's all.
Sure, Dr. Mitesh. You have the entire time.
Chat, yeah. Chat. This case, please, fast. Yes, fracture neck of the humerus. There's no obvious lipohematorosis. Next. No pneumothorax, fractured scapula. Yes. Next. Very good X-ray. This is a very good X-ray. Yeah, Saddaf has written correctly. Supracondylar Chetra has written, Amanya has written. Yeah. So always look at the corner of the image. Dr. Sandeep, very good image.
Exactly. Yeah, beautiful. I see two findings in this, Dr. Mitesh. I see the supracondylar fracture as well as there is something wrong in the acromioclavicular joint. I feel there is a
yeah. What happens that in pediatric X-ray at times AC joint is a bit tricky. Yeah. Maybe that could be another pathology. Yeah.
That could be normal, as Dr. Vikas Gupta also suggested. So I kind of agree. Yeah. Maybe we'll discuss this with a pediatric radiologist.
Oh, yeah.
And get back to the candidates. But the supracondylar fracture is definitely there. Very
great.
Good.
Now we'll go. 1 minute. Where is that? 1 minute. I'll stop sharing my screen. Last image.
Dr. Mitesh, we are not able to see your screen.
1 minute. I don't know, something went wrong. I don't know, something went wrong. It's okay, we'll leave it.
It's okay, Dr. Mitesh.
Next time we will do it.
Yeah, that is absolutely fine with us. And we'll look forward to your future sessions. I'm sure every one of us learned a lot, especially the exam going candidates that are attending this session.
Okay, now Dr. Sandeep can continue with the Viva part.
Thank you so much.
I will log out.
Dr. Mitesh, I'll just share a few points while you were showing the spotters, the radiographs. I noted down a few points on the notepad to share with the candidates. So here are a few tips which I felt just right now looking at the candidates' answers. So let me share my screen. I hope I'm sharing screen too. So here goes the notepad. I hope everyone can see a notepad on the screen. I have two screens, so sometimes I get confused. Please help me with this. Every one of you can see 6 points, right? Online notepad. So this is my suggestion would be to add the side in your answers in rapids as well as wrong cases. So inculcating a habit of writing sides wherever you get a lesion, even in your daily reporting, is good. Sometimes what happens, because you don't have a habit of writing sides, if you get a right-sided radiograph, you might end up writing a left-sided, or sometimes you don't know what the examiner wants or what is written in the answer key for the examiners of Royal College. So this has to be followed exactly as you follow in the anatomy exam. So you all have passed FRC anatomy. So this exam is a continuation of that particular exam. So FRCR part 1, 2A, and then 2B. So those kinds of habits should still be continued and not be left. Once you start reporting for NHS or UK, you understand that they're very particular about all these things. So point number 1, at the side in all your answers. The second point is be specific. One of the candidates wrote humeral fracture when the exact correct answer was fracture of the right humeral neck. So I'm sure that you won't get full marks regarding half marks or 50% marks. It totally depends on the examiner or what the answer key is. The answer key given to these examiners are always very, very specific. So it's always mentioned, if the candidate writes this, give them this much marks. So if the candidate does not write this, you deduct this much marks. So try to be as precise as you can in order to maximize your chances of passing. This is my point number 2. The point number 3 is never confuse right with left and vice versa. So one of the candidates wrote right-sided fracture when they were shown a left-sided on this particular session by Dr. Mitesh today itself. So do not do that. Most of us sometimes make this mistake in a daily reporting. Sometimes these things come back to haunt us. Start a habit. Make sure you see the radiographs, you see the particular image, and you see the side. Sometimes what will happen in the Viva, you'll be shown a case of dextrocardia with the radiograph flipped. Then if you don't have a habit of seeing the side marker, you land yourself into trouble. So point number 3, regarding first 3 points, Dr. Mitesh, do you want to add something else, or should
No, you are absolutely right.
So
you have to be specific, left and right, and specific to the part of the bone.
Okay, so before moving on to point 4, I'll complete 5 and 6. Always compare with the orthogonal view if provided. Most of the times it will be provided in an exam, 2 views or 3 views will be given. If another view is not provided, only a single image is given, then the examiners or Royal College thinks that it is enough for you to give the answer. So then you have to make do with that particular image itself. The 6th point I've written is there is no spell check in FRCR in exams. Like we have a spell check over here, Grammarly is pointing out some mistake which is not there, but in the exam you will not have any spell check. So if you have written something like this, this is something which I always make a spelling mistake with, the word thickening. So in the exam it will not underline with a red line. So if your spelling is wrong, it will be submitted as a wrong spelling. So start a habit of writing the correct spellings, and if you have a habit of making spellings wrong, check after typing. Sometimes they might deduct marks for very wrong spellings. For minor mistakes, minor spelling mistakes, they do not deduct marks. But for something like hyper intense, if you mix the spelling, then you are going to lose marks definitely. Coming back to the last point, we definitely appreciate Dr. Mitesh's checklist. It was wonderful, and I hope everyone follows that particular checklist. But as a matter of personal opinion and something regarding what I did during my own exam, there will always be excellent checklists like the one Dr. Mitesh shared, but then sometimes what happens, we all have different kinds of mistakes. So Dr. Mitesh might be making a different mistake with a shoulder radiograph, and I'll be making a different mistake commonly. So for example, sometimes what happened, I used to miss the thin pneumothorax very commonly. And maybe for Dr. Mitesh, he might be missing something like a supracondylar fracture in a shoulder X-ray. So for Dr. Mitesh, the first thing that he should look for in that particular shoulder radiograph is supracondylar fracture. And the first thing that I should be looking for it is the pneumothorax, so that I or he doesn't miss those particular findings. So make sure that your checklist is personalized for your kind of mistakes, and you are seeing the things that you commonly mistake with. Those are things you're seeing first. So these are the 6 points, those are just written by me right now. I'll just close this, and I would request Dr. Mitesh to give us a final quick talk on what he thought about today's session, on what he thinks about.
Yeah, you are absolutely right. All 6 points were very relevant, And Dr. Sandeep, I have got that X-ray. If you allow me just 30 seconds, I want to show that
Yes,
X-ray.
Dr. Mitesh, sure, you have the time.
Okay, I'll
So
start sharing my screen.
please do.
So this is it.
I don't
Last
think we can see
X-ray.
your screen, Dr. Mitesh. Can other candidates see Dr. Mitesh's screen? I cannot. So no is the
Oh,
answer, Dr. Mitesh.
no.
You need to share the screen.
Okay.
I have given the permission so that you will be able to share the screen.
Now,
Yeah, so I'll tell you what, it was a mistake from my side. I was sharing my screen, that's why we weren't able to see yours.
okay.
So apologies and thank you, Dr. Saima, for pointing it out.
Now,
Yeah.
can
Yes, we
everyone
can.
see my
We
screen?
absolutely can, yeah.
Fine. Last closing X-ray. Oh, great, great. My God, many candidates have written left AC joint. Dr. Sandeep, I reported this X-ray this afternoon, and I was quite perplexed see this right AC and left AC. How beautifully and
Perfect.
shoulder joint in a chest X-ray we can see the difference in the AC joint. Perfect.
Brilliant.
Raina, Amani, Vikas, everyone has written. Another X-ray, same patients. Here we can see clear cut AC joints widening. So in this point, in this what we can notice that there is no step-like defect, but there is clear-cut widening. Not only in the AC and CC2, there is a widening. So it's coracoclavicular ligament injury also. AC joint disruption, yes, you can. That's all. Dr. Sandeep, thanks
Thank you
a
so
lot.
much, Dr. Mitesh. Brilliant X-rays, wonderful. I hope I got to report such X-rays, but then I sometimes feel it's better not to get such type of complicated ones as well. So thank you so much, Dr. Mitesh. Regarding AC joint disruption, I would suggest everyone not to use short forms. Just as in the FRC anatomy exam, use the entire term right acromioclavicular rather than writing AC. All these things will make you lose marks, so do not do that. Make it a habit. So what we do in practice is what we end up doing in the actual exam. So if you're doing this mistake in habit, if you're taking it lightly, you're very likely to make the same mistake again in the exam, and then sometimes even that 0.5 marks make a lot of difference. So thank you so much once again, Dr. Mitesh, and we thank you and we hope that you will show us more radiographs in the coming sessions. We would love to have you here as a presenter.
Best of luck, all the candidates.
Thank you, and
Bye-bye.
good night, Dr. Mitesh.
Bye-bye.
So we'll move on to candidate 1 now. I'll just ask candidate 1 to unmute. So candidate 1, are you here with us? I have asked you to unmute if you can.
Hello. Yeah.
Yeah, candidate 1, you're there, right? So
Yeah.
I think we are quite late now. It's 11:30 p.m. India time. So we'll try to quickly wrap up the 2 Vivas. And I think I'll give you 10 minutes rather than 15. And then whatever cases you can complete, we can discuss. Is that fine for candidate 1 and the rest of the people?
Sure.
So let me see the cases that I have collected, and I hope I am sharing screen too. Can you see an axial CT scan?
Yeah.
And I will just give you the control. Candidate 1, see if you can click to my request and start controlling my screen. Can you do that? And then we are good to begin. Yeah, so you can. Please don't scroll yet.
Okay.
You can either use this method that you're seeing on the screen, or if you have a mouse, you can just scroll up and down. Or the third method, and something which I use in my exam, was to use the up and down keys. Okay, so candidate 1, please stop there. Please stop there. I haven't started your timer yet.
Sorry.
Since you can control, I was just checking so that you were good to go. So I start your timer now and you can start scrolling.
Okay, I'm presented with axial section of a CT abdomen portal venous phase. I like to go through the entire images first and would like to discuss about it. So I can see there is increased density involving the mesentery with fat halo surrounding the mesenteric vessels. These findings are inconsistent with mesenteric panniculitis. I like to review my review areas like the vessels. There are no any thrombus seen in the vessels. I can see there is a incidental gallbladder stone seen. Rest of the findings appears to be normal. In summary, my most likely diagnosis is mesenteric panniculitis. This is a benign finding and often get resolved with inflammatory drugs. So I'll refer this patient to the referring. I'll inform my finding to the referring clinician, and this patient will need to be treated with anti-inflammatory drugs.
Okay, have a look at this case, please.
So I'm presented with a spot image of fluoroscopy showing there are multiple trabeculations seen involving the urinary bladder, and the shape of the urinary bladder is also appears abnormal. So this appears abnormal, and there is also a reflux seen involving the left side of the ureter. In my routine practice, I'll review the entire fluoroscopic image. So I'm presented with the oblique view, which shows there is also a urinary bladder catheter in situ. So in summary, given the appearance of multiple diverticular and trabeculation with the abnormal shape of the urinary bladder and the reflux into the left ureter, my most likely diagnosis is neurogenic bladder. And I can also see, I like to look for the posterior urethral region.
Okay, we'll just stop there. So you're good. And we'll go to the next case now. Here's the next case. Patient presented to us with severe abdominal pain.
Okay. I'm presented with axial section of a CT abdomen with the patient who presented with abdominal pain. I'll quickly go through the entire image first and would like to talk about it. So I can see there is a dilated bowel loops involving the upper as well as central portion of the abdomen. I can also see there is abrupt transition point with transition point appearing like big appearance, and this is also and also the cecum is also not at the normal position. So the most likely appearance of this is the cecal volvulus. Looking to my review areas, I like to look for if there is any pneumoperitoneum or if there is any ischemic changes in the bowel loops.
Okay, why cecal volvulus? Where is the twisting?
Sigmoid appears to be Okay, the twisting has started from the sigmoid. I like to revert my finding. The dilated bowel loops is starting in my routine practice. I'll also have to look. I look in the coronal section.
Candidate 1,
Yeah.
before you look at the other sections, I would ask you to request first.
Yeah. Can I have a look at the coronal section?
Which section do you want?
Coronal.
Yeah, it's all yours now.
Thank you. So the rectum appears to be collapsed, as well as the descending colon also appears to be collapsed, and there is a twisting seen at the level of a sigmoid colon, and there is also no any Hostressen marking seen in the dilated bowel. So my most likely diagnosis is a sigmoid volvulus. This is a surgical emergency. I'll immediately pick up the phone and inform the referring clinician, and this patient need to be referred to the surgical team for further management.
Okay, you've completed the case, but just for the sake of the discussion, I'll pause the timer and I will show you a topogram. Just describe what you see on the topogram. I agree with your final diagnosis and the rest of the findings.
So the topogram and image shows there is a dilated bowel loops involving the central portion of the abdomen. That is appears to be arising from the pelvis and is growing to and is expanding towards the right hemidiaphragm. I am not able to see any Hostressen marking, and the rectum, there is no any rectal gas shadow seen, as well as the descending colon appears to be collapsed. And there is no rectal gas seen, and some dilatation of the descending colon is seen. So these findings are in favor with the diagnosis of sigmoid volvulus.
Okay, candidate 1, I'll resume the timer, and this is your next case. You can scroll.
Thank you. I'm provided with a MR image, coronal section of a wrist joint. T1 section. I can see the lunate bone appears to be small in size, and it appears to be hypointense. So the appearance, and also I can see the ulna is slightly above the level of the radius. Okay, I can see the lunate bone shows loss of the T1 hypointense signal. It is suggestive of vascular necrosis of lunate bone, suggestive of known as Kienbock disease. I'll refer this patient to the orthopedic department for further management and evaluation.
Okay, so regarding the management, what do you think would the management be?
The management will be resection of the vascular bone.
You said something about the ulna, though it is not seen in this.
Yeah, there will be negative ulnar variance.
Find in the case of, so what would you find in the case of Kienbock's disease?
Negative ulnar variance.
Okay, so we'll go to the next case. Here is your next case.
I'm provided with a frontal radiograph of a pelvis and bilateral hip joint of a skeletally immature patient. I can looking to my review areas. I like to focus on the bilateral femoral head. I can see that in bilateral side, I can see on the left side there is some epiphyseal growth plate widening is seen.
Where could you point it out for us?
On the left, there is some widening of a left epiphysis.
Yes, candidate 1, could you please point it out with your cursor? Your mouse, where do
Yeah,
you think?
yeah. There is some epiphyseal widening on the left
Are
side.
you sure about it? If you compare it to the right side, does it look widened or?
So, yeah, it looks like similar. The in the left humeral head, it appears to be radiolucent compared to the right humeral head.
That could be
It
due
could
to
be due to
the,
projection.
yeah, could be due to that. What else you see?
Okay,
I would
I
point
can see
you
there is a
towards, yeah.
I can see there is a radiolucent lesion involving the cortex of the left proximal metadiaphyseal region. The lucent lesion has a well-defined sclerotic margin. So, and there is no any aggressive type of. I am not able to appreciate any aggressive type of periosteal reaction, and there is no any soft tissue swelling. In my routine practice, I'll also like to look for the other views to look other orthogonal views to look for the periosteal reaction or cortical break.
So what are your
Uh,
differentials from this
so,
particular radiograph itself?
so this is a non-aggressive lesion and differential diagnosis of cortically vest lesions. One of my differential diagnoses was osteosteoma. Other differential diagnoses are Brody's abscess, and also enchondroma or enchondroma. So this is a non-aggressive lesion, and we'd like to further evaluate this with CT scan to look for the nidus. And we'd like to refer this case to the orthopedic department, and if the CT scan shows the nidus, then the diagnosis will be osteosteoma,
Okay.
and the
So
treatment
I'll
will be
show you
NSAIDs.
the next set of images, and I just noticed one of the participants was trying to annotate that candidate has been removed from the session. So if you try to annotate or interrupt the meetings, you shall be removed from the sessions. So this is the same patient. I want you to complete this
Okay,
case. This is your last case for today.
The CT scans confirm my finding of nidus is there with a sclerotic rim. This finding is suggestive of osteosteoma. I'll refer this case to the orthopedic department and need to be treated with radiofrequency ablation.
Okay, so that would be all for candidate 1, and I think you did well, candidate 1. You tackled all the cases with confidence, you were clear and you were calm about it. So this is a case of osteosteoma. This I had to point it out to, but then I agree that there is some difference in the lucency, and then it sometimes will confuse you, but then look at the entire picture, and it's always better to compare the two sides, which you did. So I agree, this was osteoma. This was a case of Kienbock's disease. Yes, the examiners will help. Dr. Prabhakaran has a question. He says, do examiners help like you did? They will help you at the last moment. If they've given you enough chances to see the lesion and then the time is running out, you wasted more than 2-3 minutes and you aren't even able to see the finding, then they'll try to focus you towards the part of the image where you have to see. Even after that, if you are not able, sometimes they'll tell you where to look. But this again differs from examiner to examiner. Some examiners might just skip to the next radiograph, some might try to prompt and help you. So you have to be ready for all kinds of examiners, a strict one and a cheerful, helpful one as well. So we come back to this particular case, Kienbock's disease. I'll be just quick with it, and I'll share the entire playlist on the June as well as the September as well as the essentials group, so that you can go back and see the other findings as well. Kienbock's disease, and you have to speak about the ulna as well, because negative ulnar variance is present as a predisposing factor in 75% cases of Kienbock's disease. So you can read it about this in Radiopedia in detail. No, in this particular case, I don't feel that negative ulnar variance is present, but you have to look for it and speak about it in a case of Kienbock's disease. Coming to this case, this is a case of sigmoid volvulus. So you can clearly see that this is the rectum, and then if you trace it back, it is clearly a case of sigmoid volvulus rather than a cecal volvulus. You have to know the differences between cecal and sigmoid volvulus. Just for the sake of time, we'll not go into the details of it in this particular session. I'll share it in the group. This is a case of neurogenic bladder. This is a classic spot in MD, DNB or any other radiology exams in our respective countries. So it's a Christmas tree or a pine cone tree appearance. And there is also a vesico-ureteric reflux on the left side. So candidate 1 was perfect in stating all the findings. This case, mesenteric paniculitis or sclerosing mesenteritis, it has 2 names, I think some more names as well if you go to Radiopedia, but mesenteric paniculitis is a commonly used term, and this is a self-limiting disorder. Patient usually presents with pain, and sometimes what will happen, just to state that there is a gallbladder calculus as well. I won't say this is just an incidental finding, because sometimes the calculi in these locations, especially in the neck, might impact and cause resultant cholecystitis. So that also has to be treated as a significant finding. Sometimes they might just show you, it was a plain scan. So he did say it was a venous scan, but it's just a plain scan. Sometimes the examiner will correct you, sometimes they won't. So if you are in a lot of doubt, you may ask the examiner, I am not able to make out if this is a post-contrast or a pre-contrast sequence, especially in some cases where it's not very evident. So you can ask them. Sometimes they will tell you, if it's too evident, they'll just say you can easily make it out from the image. What do you think about it? So they'll question you back. That's also a possibility. Be calm, be confident, be ready with all kinds of questions. You have to imagine as if it's a clinician who's come to your department and you're discussing a case. So treat the examiners as if they are clinicians and they're not examiners. So if you follow this mindset, it becomes much easier. And then you usually will have better confidence if you're thinking, okay, I know this case, he or she is a clinician, I know more than him or her, and I'm just describing the findings that I see in the particular case, just as I would do in my day-to-day practice. Just to finish with this image, sometimes they might show you this kind of an ultrasound image, just an echogenic avascular mass-like hyper echogenic area or a lesion. So remember, it can be shown. I personally don't think it's a very simple one to give a differential with this particular image, but the differential would still be omental infarction, mesenteric paniculitis, then mesenteric inflammation due to other causes. Maybe others can chip in a few more differentials as well. So we complete candidate 1. Regarding the discussion part of the particular cases, I'll share the respective slides and the images as well as the playlist on the groups.